Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to the Voices of Otolaryngology. I am so excited today to have Maria Michaels and Dr. Margo McKenna with us. Today, we're going to talk about digitizing guidelines, living guidelines. Us three are really excited about it, and we're confident at the end of this 30 minutes or so, you too are going to be excited about the horizon in guidelines. I'd like to introduce Maria Michaels. She'll tell you a little bit about herself.
Sure. My name is Margo Michaels. I'm actually here in my personal capacity, but I have done a lot of work in the area of digitizing guidelines in some of the jobs I've had in the past. So that includes the Agency for Healthcare Research and Quality, the Centers for Disease Control and Prevention, and through my role as chair of the Guidelines International Network North America region. Again, I am representing myself only in this podcast.
Awesome. So you can answer this question the best. As representing yourself only, could you tell us about your training, background, education a little bit? And then we'll go to Dr. McKenna.
Well, I've studied biology and psychology and do have an MBA. So I have a little bit of science and business background. I've worked in clinical research, actually a lot of different types of research, but mostly clinical research. And then ferried my way into health informatics, and I've been working on that for well over a decade at this point. And I have done things like write regulations at the Centers for Medicare and Medicaid Services on the Meaningful Use Program, if you guys remember that. I've done a lot of work at the CDC on developing computable guidelines, automating data exchange, and essentially using health IT standards to really help how we move information in healthcare and public health. So that's more or less where my background comes from and feeds into what we're going to talk about today.
Great. I'd like to introduce Dr. Margo McKenna. Margo.
Hi, thanks. I'm a pediatric otolaryngologist in Rochester, New York, at Golisano Children's Hospital in Rochester. And I got involved in the guidelines as a GIN scholar, which is Guidelines International Network, several years ago, and then started as a methodologist in training with the Guidelines Task Force. And then about a year ago, took over from Dr. Tunkel as the chair of the Guidelines Task Force.
Awesome. Thank you so much. Maria, what makes guidelines so exciting? You've devoted a lot of your personal career ambitions and passion towards guidelines. Why?
Well, it's basically the scientific basis of how you treat patients in clinic, in hospitals, and an operating room. Basically, the sort of scientific rules, if you will, that are based in science that help us actually provide the care that patients need day in and day out, pretty much 24/7, 365. So what better way to devote any part of a career than to really support the way that we deliver those really important pieces of science into clinical care.
And you are not an otolaryngologist.
No,
we're so appreciative of you working with us as otolaryngologists to help us think about how we make guidelines living and digitizing them. Margo, Dr. McKenna, GTF, Guidelines Task Force. Demystify that in 60 seconds for our members.
That's a good question. And we've been working on our website too to make it a little easier for people to understand exactly what it is that we do and what we're for. The Guidelines Task Force is a group of people that are representatives from a lot of our sister societies. So someone from the American Society for Pediatric Otolaryngology, from the ARS, Head and Neck Society, Laryngology. All of those people come together twice a year, once in person and once virtually. And we discuss topics that may be eligible to become a guideline. So let's say, for example, someone puts in a recommendation that we should have a guideline on pediatric hearing loss. The guidelines group, the GTF, will sort of look at what literature is available out there. Do we have enough literature to support a guideline? Because that's a really key part of the process is, we want these to be evidence-based. And if there isn't evidence, then we can't make something into a guideline. And then that GTF group will vote on how feasible it is and how much, leverage we have to make that into a guideline. And if something meets a certain threshold from all of those people that are there in the room, that it goes into our queue and then eventually becomes a guideline in development. So as an example, that one for pediatric hearing loss is actually coming out for development shortly.
Wonderful. Thank you. And I'll say for our audience that's listening, in our journal, Otolaryngology Head and Neck Surgery, the biggest impact or readership comes from our guidelines. Did I say that right, Dr. McKenna? They're really some of the most popular articles.
The most cited articles as well.
Yes. Thank you. That's the correct word. Thank you for the verbiage. Most cited articles. So Maria, your passion is guidelines. Margo explained the process, and this has become your passion on how do we decrease the cycle time. Talk a little bit about, Margo did a beautiful job explaining the process, and it's a reality, but your work and some of your national work is, well, maybe it's not a reality. We can do guidelines faster and perhaps better. Maria.
Yes, well, we're trying to make it more of a reality across the board, across groups that develop guidelines all the way through to their implementation in practice. So really what we've tried to do is think of the entire process from the beginning of evidence generation all the way through to implementation and even beyond that to evaluation, so that you can constantly kind of have this learning loop that happens, sort of this learning health system. And one of the things that we were able to figure out is that if you re-engineered the process to do things simultaneously rather than in tandem, that you would be able to actually potentially cut those cycle times to be much shorter. And in addition to that, if you have or sort of commingle different disciplines like informatics and the scientific expertise that is usually part of a guidelines task force, you can actually have complementary approaches where the informatics person will really sort of break down the details of how a computer might need to understand the guidelines to really help guide, again, during that clinical workflow, while the scientific members of the guideline task force can focus more on the science and then potentially have a way to know whether the way that they've spelled things out in a recommendation is actually as clear as they think it is. So it's very complementary and mutually beneficial to have multiple expertise kind of working together in a guideline task force in a way that's been different than in the traditional approach.
Margo, when you think of the Guidelines Task Force, the work, you're continuing a tremendous legacy of leaders that preceded you, and you're doing a terrific job. So thank you. What does that mean for us in terms of cycle time, working in parallel versus serial?
We really have to go back to the beginning. You know, in the past, we've gotten through the entire guideline process of development, and then at the end, we think about how can this get translated into the EMRs that we use on a regular basis. But what Maria is talking about and what we hope to do is go back to the beginning. So when we start a guideline, and again, this is different from the guideline task force, which is overlooking the whole group. Each guideline has its own guideline panel. And that guideline panel starts by looking at the topic, reviewing the literature. Right from that first step, we need to be thinking about how can we make our recommendations digitized, how can they be integrated into the EMR, rather than trying to go back from the end and rework it.
And what would that do to our cycle time or reach or impact? What benefit would our members see?
I think our goal ultimately, and I will ask Maria to chime in too, is that rather than having this guideline on we still have our pocket guide that is like something that goes in your white coat, which obviously the younger generation doesn't use anything like that. We still have a printed paper copy of this guideline, but what we want to do is have it integrated into the EMR so that if you see someone that you think may have Meniere's disease, that you're walking through the guideline as to like, this is the next step for diagnosis. We should be ruling this out. We should be getting this testing. We should not be getting this testing. And it's right there at your fingertips instead of having it be something that you have to go look up in a journal.
And Maria, then am I using the right word when I say that goes to digitization? And you talked about coding. And can you talk a little bit about that with your informatics background?
Sure. So the digitization really comes from using health informatics to turn the words in the recommendations into something a computer can understand. So the EMRs that Margo mentioned, and it gets incorporated then into the flow that is within that EMR. So unlike in the traditional way that you use guidelines where you might read a PDF or read a pocket guide or anything that's on sort of a physical piece of medium, in this case with digitized guidelines, it not only brings the guidelines into that EMR so that as you're seeing the patient in the correct place in the workflow, ideally, you'd be able to see the information that you need as you need it, but it also actually uses that patient's data. So it's not even just a matter of knowing the guideline, but it actually reasons that guideline over the patient's own data so that when you're getting a recommendation within the EMR, it is a combination of the guideline and that specific patient's data, which gives you a more personalized recommendation to consider.
Fascinating, Maria. So it takes me, 50-year-old male, let's say I have Bell's palsy over a certain time frame. It would know my age. It'd know my risk factors. It would obviously know my gender. It'd know the duration of symptoms because I might have seen Dr. McKenna in the office 29 days ago and not 21 days ago. And then it would help me follow that it would help Dr. McKenna. She's the doctor. It would help her follow that, correct? Based on my data. Exactly.
And, if you think about it, there's so many guidelines out there that you have to kind of keep in your head as a physician, that this is a way to kind of have a backup, if you will, for the guidelines themselves, but something that you don't have at your fingertips, if you will, as a physician in the clinic, in the OR, is really the patient's data. Like you'd have to go look for it. And sometimes it's not as easy to find. Whereas if you program the computer with the digitized guidelines, it should be able to find that data and kind of bring it to the forefront for you. So it not only helps again with bringing that guideline there so that you know what the recommendation is about, but it also tells you how it applies to the specific patient. In your case, the 50-year-old male with Bell's palsy.
And before I go to Dr. McKenna, Maria, you're a national and international expert on this. What specialties are doing it right?
Well, different specialties are trying different things. I know primary care is an area that is particularly right for something like this, since in primary care, those physicians need to really think about a lot of different ailments that potentially could be of issue. And so being able to really apply this in primary care would be excellent. I know that there's a lot of surgical specialties that have really tried to do this, in particular to help make the areas of operation, especially before surgery, smooth and again, potentially apply any guidelines that are necessary to a particular patient more easily done. So those are really the areas that have kind of focused on it. But I would say that there's no one specialty that has sort of run with this. So we're really excited that you guys are so interested and hope that this actually continues to scale so that we can ultimately get these guidelines into practice a lot more quickly, easily, accurately, and consistently.
Well, we're a specialty that likes to run and try and give patients great value. So we're excited that you're helping us pilot this for our members. Margo, Dr. McKenna, I can think of some bad ways where digitization can go wrong. You could track my adherence. You could penalize me through payers. You could say that I'm overuse. But why don't I have you talk about the pros and cons, perhaps? And everybody knows how we do these podcasts. Nobody knows what questions I'm going to ask. I don't even know. So Margo, I just gave you a little filler there for 20 seconds so you could think of a thoughtful answer. But Margo, then Maria, what are the pros and cons of digitization of guidelines?
I think from the clinician standpoint, definitely having it at the tips of your fingers seems like it would be helpful. And one example that's integrated into our EMR, it is for sepsis. A little box will pop up.
Yes.
This patient has a fever and tachycardia. Do you want to institute the sepsis protocol? So that's the kind of thing that we would be looking for. And it can overcome a lot of that, the alarm bell, way that you can kind of tune those out. So it brings things to your attention that you might not otherwise see. From the flip side, this has always been a concern, and it's a concern with our paper guidelines as well, that if there is something that's on paper that says you shouldn't get vestibular testing for a patient and you do it, is that something that will be, you'll be held accountable for in some way? We do always put into the fine print. Each patient is different. These are at the doctor's discretion, at the provider's discretion, because they're used by nurse practitioners and PAs as well. So at the provider's discretion, based on individual clinical factors. And if you can support that based on your thinking, then, it's not something that the paper guideline will be punitive in that way.
Yeah. Maria, anything to add to that in a positive and negative sense?
Sure. Well, the main negative, I'll start with that first, is that it's possible that some of these digitized guidelines could be programmed incorrectly, not on purpose necessarily, but that's probably the main negative. Wow. And one of the areas that can be challenging, I wouldn't necessarily call it a negative, but in those scenarios like Margo just described, where it really depends a lot on the provider's perspective and really their ability to look at that particular patient and make a judgment call, that's not ideal in a digitized guideline, because the computer's not going to make that judgment call, right? That's what the physician is there for. So that's probably the biggest negative. However, in a positive way, one of the things that this could really help reduce is what I call unnecessary redundancy in how guidelines are implemented. Most of the time, these paper guidelines go out, whether there's pocket guides or anything else like that could facilitate the use of those guidelines. Almost always, healthcare organizations will take those guidelines and turn them into clinical decision support. Essentially, they're turning them into a digitized guideline within the clinical workflow in the EMR, but they're each doing it individually. So they're taking all of this time and trouble and potentially not necessarily interpreting it correctly. So in this case, if you start with a standards-based digitized guideline from the source of truth, from the guideline organization, then you can put that standardized version out there, and each organization can then apply that in their own system. So it helps them actually take that guideline and put it into their clinical workflow in a more consistent way than each of them individually trying to do the same thing.
You talked about, or you're getting to the word adoption. How do we then work with the EMR vendors, the 4 or 5 dozen predominant vendors out there, to get a digitized guideline there? Or do they just pick it up, and who owns the IP, and what's the national discussion on this topic?
Well, who owns the IP is still sort of up in the air. I would like to think content-wise, it should be no contest. It should be whoever's guideline it is, so the medical society in this case, should own that IP. That potentially the digitized version, depending on who develops it, could belong to someone else. Each of these EMR companies should be able to take the health IT standards that are out there and apply them within their own systems. Some of them turn some parts of those into some of their more proprietary components of the system. But generally speaking, the health IT standards that are out there are free to use and available internationally. So those should really help get kind of a scaled version of a digitized guideline out there and available to be implemented into individual systems.
Yeah, very well said. I understood that. So thank you. And that's a testament to your ability to explain it to me. So thank you. That was great. Margo, what excites your group about digitization? What do you think our timeline is? And then I want to spend the next segment of this talking about living guidelines, and I'll have Maria define that.
Yeah, I mean, at the past Academy meeting, we presented a panel about this where our staff members at the Academy took the Meniere's guideline and did some of this early digitization process. So they did go back to the beginning and start with a guideline that's already published. So not the ideal way that we want to be doing it in the future, but at least a proof of concept. And we're able to map out the processes that would be necessary and code them and digitize them. And then that coding, which is specific to the guideline, can then get extrapolated out to the different EMR systems. So there's a few different steps, but it was really exciting to see that our team could do that and did do that for this guideline. I think that says a lot about the future. And I just give 100% credit to the Academy staff who are, working behind the scenes and actually doing the work to get that done.
Yeah, thanks for that shout out. The Academy staff under research and quality are very passionate about this and have really made it a feather in the Academy's cap to deliver member value. So very well articulated there. So let me just make a facetious statement. So digitized guidelines are not just a PDF thrown there in the EMR. It's actual digital coding and logic and algorithms.
That's correct.
Yeah. And as you said, Maria, that's where some of the IP is there. Because by developing that logic and algos, there is value there.
Yeah, so the algorithms, again, represent the written guideline, the narrative guideline that the guideline panel develops. So there's still that question of where the IP actually remains, but the digitized versions should use health IT standards that, again, are free to use to anybody. So in that sense, they're not necessarily IP that has a copyright that only the EMR vendor owns. However, all of them should be able to leverage it.
Margo, please.
I was just going to use an example that Maria came up with that really helped me understand it, because coming from a clinician standpoint, I don't always have all of the IT background, but it's like going from a paper map, which is our written guideline, to something that's like a GPS that's on your phone. So people don't even ask for directions anymore. They just put the address in and the GPS takes you right where you're going to go. So that's what we're trying to get from the paper map to the fully implementable digitized version.
And then let's take that analogy one step more granular. And then the old school was when you would go to Google Maps and you would print it out, and then you'd have that printout in your hand. And Maria, that's what I think you're talking about. We're moving towards digitization, but we don't want to fall into this valley of death where we think printing something out is digitized. No, no, no.
Correct. So a PDF is not a digitized guideline. It's essentially a paper guideline.
That's
you just
right.
can see it on your computer.
Really well said. When you used to print it out on Google Maps, it was still a printed map. It just came from your computer. So living guidelines, who wants to take a stab at that? Because when I told people we were recording this podcast, they said, oh, great, you're going to talk about digitization and living guidelines. So we addressed digitization, but living guidelines, who's going to start there?
I can start with what the process is now for our updating of our records. The guideline takes about 18 months to have the panel together, do all the searches, collate the evidence and come up with the key action statements and get it published. Every 5 to 10 years, those ideally should be updated, meaning we go back and we re-review the literature, we add things that weren't there before, and we publish it again. Even the update takes at least a year, if not a little bit longer. The more guidelines we publish, the more updates we have to do, and it becomes an untenable situation where we just don't have the bandwidth to do that. So one thing that we are trying to do, or trying to move slightly toward, because it's a huge process or project, is to make the guideline more of a living document.
Very well said. Maria, you would like to add to that? That was beautifully stated.
Yeah, I mean, the main thing I would add to that is on the digitized side, there's ways to take the components of the algorithms and update just those components and then test them to make sure they're not affecting other parts of the algorithm. So there are ways to apply a living guideline approach in the digitized version too.
Exactly, Maria. And I just wrote that. There's kind of this interplay. If we have living guidelines, digitization accelerates that. It's almost accretive, or it's a multiplier effect.
Exactly.
Margo.
One thing too about having it in the EMR is we can see what people are actually doing. Right now, if the paper guideline is out there, we don't know who's following that. We don't know if anyone's following it or even reading it, other than downloads. But if it's in the EMR, we can see, how many clinicians actually did X, Y, and Z, and that can feed back to the guideline development process and say, like, 90% of physicians are already doing this. Do we really need to revamp the whole thing? And there's a huge potential as a separate topic for AI to be helpful with this too. I think people are carefully wading into those waters of, could AI be helpful in reviewing the literature or summarizing some of the newer papers that have been published in the last 5 or 10 years, to present that to the clinicians who can then go through and decide if an actual huge update is needed.
Yeah. I coded in high school and a little bit in college. So let me make this an if-then statement and impress you with my coding words. So if medical knowledge evolves every 3 to 5 years, then an 18-month cycle time and a 5 to 10-year cycle time is absurd. And I mean that just respectfully, right? And I know you know that, Margo and Maria, and our committee members know that, but that's all they've been had. Paper processes, sending documents back and forth. So talk a little bit about the exciting potential, Margo and Maria, of digitization helping living guidelines with an academy partner, open evidence, or with other kinds of tools.
You said all the words of all the things that we're trying and attempting to put together. And if you look across the world, some places are doing this, but it's still very resource intensive.
Exactly.
So I think there's still a lot of barriers to overcome, but ideally, yes, we would have the evidence and it would be in a guideline right away so people could use it if it's good evidence, and we're just not there yet.
Yeah, and I use the word absurd in a joking sense because it is reality. It is so hard to get it right, to get a 40 to 50 page document right. And Maria spoke a little bit about AI or technology, and your biggest fear is something gets coded wrong. Our biggest fear, right, Margo, is if we use an algorithm or do something to accelerate it, we hurt a patient. Never want that to happen. Maria, bring us up to speed on those discussions. What are some of those national discussions regarding living guidelines and cycle time of medical knowledge?
Sure. And I'll just add that what you said about the hurting patients, that is the main concern with coding something wrong. You don't want the wrong recommendation to happen and then be followed in that case and then cause harm. So what we want to be able to do, though, in the case of living guidelines especially, is be able to, once you've implemented a digitized guideline, almost incrementally be able to update it based on any new evidence that affects some portion of a guideline, like one recommendation, for example. And in that way, you can update something like an age range that might have changed, or an additional test that's needed, or maybe one fewer test that's needed, or whatever the case may be. That should be a relatively easier change than having to re-implement a new guideline every 5 to 10 years, or a guideline update somewhere more frequent than that. So it's definitely an approach that should ultimately cut down the cycle time. And what that really means for patients is that the most up-to-date scientific evidence can get to them faster.
Very well said. And Margo, we know from our colleague, Dr. Cecilia Schmalbach, the editor-in-chief of our journal, there's been an asymptotic rise in scientific literature. It's humanly impossible to get our head around it. We probably could in the 90s and early 2000s, but it's now amazing how technology is coming together to help us. We never could have had living guidelines before. Margo, do you want to talk about that? The evidence burden is just exploding.
It's huge. And it is, the guidelines, the chair of the guideline is a surgeon, clinician. And in some areas, they have the chair of the guideline be responsible for kind of surveilling the evidence over time. I don't think that's realistic to expect someone to be surveilling the evidence. So, we are lucky to have the academy staff that can help us with this. We have a search strategist who is outside of the academy, to help our clinicians so that we can use our medical knowledge and resources to kind of vet through it, but not be responsible for reading every paper that comes through the journal. It's a lot. It's too much. And again, AI, there's a potential for that to help as well. But
Well, let's spend maybe a couple minutes on that. Maria, let's talk about the potential for augmented intelligence, artificial intelligence, large language models. What do you see, Maria, and then Margo, as optimism? You've talked about the caveats, but how will this help us in the next couple of years as we accelerate living in digitized guidelines?
Well, there's definitely research going out there to see how consistent these large language models can be in using AI for different components of the guideline development process. Margo talked a lot about the evidence portion. I think that's probably the most far ahead than some of the implementation or even guideline development aspects. That it can constantly be looking for updates in the literature. For example, it could summarize that literature. It could help provide maybe a beginning summary of what's out there and how it potentially could apply into guideline recommendations. Where I know there's research out there looking into how it could potentially then leverage that evidence in conjunction with health IT standards to put a draft recommendation, a digitized recommendation out there. That's again nowhere ready to be ready to go live, but that's some of the areas that are being looked at in terms of the development side. On the implementation side, there could be ways that AI could be used to help take a standards-based digitized guideline and implement it into an individual system based on, for example, like an Epic platform. They would be able to apply the AI to the standards and then incorporate it into the workflow of that EMR. It could potentially also help even within the clinical workflow and augment based on information that's being input for a patient. So some of that patient's data could be applied in ways that AI can help sort of augment or facilitate what the clinical decision support algorithm is doing within the workflow. So all of these things are being researched right now and trying to see how consistent it can be without producing things like hallucinations that we hear about, which would definitely not be good for patient care.
Yeah. Margo, what future do you see as a clinician with AI integration? We've talked a little bit about it. I ask, what do your med students have in their white coats? Remember what we used to have? We had Harrison's, we had our stethoscope, we had our KJ Lee, right? Our white coats were full of stuff. But your med students, what's in their white coats, and what do you see as AI from a clinical perspective with guidelines?
It's completely changed, from all the little paper books that we had.
Exactly.
I have been using open evidence a lot. I think that that's, just scratching the surface of what's possible, but it's so helpful in the way that it smartly presents the evidence to you in a summarized way. So I think there's a lot that's exciting coming up, but hard for me to know which direction.
Yeah. You mentioned the academy staff. Can you talk a little bit about your volunteer cadre? I think the Guidelines Task Force is about 25 folks. And then how many folks are involved with the panels? I'd say there are about 100 plus otolaryngologists that are involved with the laborious process and the high integrity process of guidelines. Am I right in that, Dr.
That
McKenna?
is correct. Yeah. And there's a group of about 5 to 10 methodologists and methodologists in training who kind of help steer the guidelines in the right direction, make sure that separate from the content, but just make sure that we're following our process each time. And those people will do multiple guidelines back to back, and same with the academy staff who are there to kind of help facilitate the entire process and keep us on track. And then all of the physician volunteers. And that's not only otolaryngologists, but for example, the sinusitis update that we just did has someone from infectious disease, someone from allergy, so it's multidisciplinary, always a patient advocate, usually someone that is either a nurse or a nurse practitioner who provides some input as well.
Maria, we're going to end with you, but before I do that, Margo, we're both pediatric otolaryngologists, so we see kids and development. So somebody wants to grow up to be Dr. McKenna. They want to be chairwoman of the Guidelines Task Force. How does that happen? What's been your path, and what guide or mentorship do you give to those that want to be what you do one day?
I think there are two key things as a young attending or resident or fellow. One was if you're on an academy committee, then you have a high likelihood or at least a chance of getting on a guideline panel, which is one of the first steps, because usually we will send out a solicit from all the different committees who are relevant to that guideline to send us a panel member. And that's how I got involved from the Pediatric Otolaryngology Committee onto the guideline panel for epistaxis, because it started at age 2. That guideline is specific down to age 2. And the second thing was the Cochrane and Ginn Scholars Program, which is through the Academy. So applying for that fellowship program, which has been really such a great program over the years to get people involved in systematic reviews, quality guidelines, and then those people sometimes will pull them in as leadership for the guidelines, chairs, assistant chairs.
Thank you for that. So we can all grow up to be like Dr. McKenna if we started a committee. Thank you for your service and friendship over the decades. Maria, why don't you end us with a blue ocean? So you've devoted your whole career to this, putting together biology, sciences, medical informatics, public service. You do this on your volunteer time. And so we're so appreciative of you. What does a blue ocean look like? Bring it home when somebody sees your family member or sees you. What do you see out there, Maria?
Well, ideally, a patient won't even know that there's something in the EMR helping guide things. In fact, maybe the clinician shouldn't know either. It's just that seamless. So in an ideal world, there would be this kind of seamless aspect that just helps but doesn't impede what's happening in clinic or in the operating room or in a ward in the hospital. So that's on the sort of user end of it. On the back end of it, ideally, we'll get to a point where maybe we do figure out how AI can really enhance the ability to digitize the guidelines and get them into those EMR workflows in a way that ultimately creates that seamless experience, that we are able to cut those cycle times down. I think the number still out there is an average of 17 years to get scientific evidence into practice. That is entirely too long. We really should be able to cut that down into much, much shorter cycle times and ultimately, like I said, get that scientific evidence, that up-to-date, cutting-edge scientific evidence into practice, into patient care much more easily, quickly, accurately, and consistently.
One of my favorite phrases is 10x. We always want to multiply. And so 17 years, Margo, you're going to regret me learning this because now I'm going to say 1.7 years, and I think we'll get there. Don't you think, Margo and Maria?
I do. It's really exciting. I do think we're on the way to getting there.
I want to thank you both for getting me excited and our members excited, educating us about the guidelines development process. Very important. We all use the guidelines in our practices. Again, they're our most cited articles, our most read articles. But here we talked about how we make them living and digitized. Maria, Margo, thank you both very much for carving this time out of your day to educate our members. Thank you.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.